Thank you for the invitation to present at this year's Middle Eastern Federation of Medical Physics virtual meeting. This lecture will look at the current practice and future directions of radionuclide dosimetry. In terms of learning outcomes for the lecture, after this presentation, attendees should be familiar with the basic history of radionuclide therapy, have an understanding of the changing role of dosimetry, be familiar with the current standards for dosimetry, and have a greater understanding of the current developments that are shaping our approach to radionuclide therapy practice. Radionuclide therapy essentially began with the investigation of radioactive iodine to treat thyroid disease. In 1941, a physicist at MIT, together with Sol Hertz, who was an endocrinologist at Massachusetts General Hospital, began to administer repeated doses of radioactive iodine to patients with hyperfunctioning thyroid disease and noticed that the hypothyroid clinical state cleared. In 1942, Keston and Franz of New York observed radioiodine uptake in bone metastases of patients who had metastatic thyroid carcinoma and had undergone previous thyroidectomy. Then in 1943, Sam Sutherland in New York evaluated a thyroid cancer patient who had a mass in the skull that was seen to concentrate I-131 in kinetic studies. He decided to see if repeated doses of I-131 would relieve symptoms of the thyroid hyperfunction whilst maintaining a stabilization of the mass in the skull. The results were more impressive than this, and the mass decreased in size as well as the hyperfunction coming under control, and this patient went on for several years to have an improved quality of life. Years later, in 1981, there was a report on the incidence of recurrence and death in patients with relatively small papillary thyroid carcinoma who were treated by surgery alone versus those who were treated by surgery followed by iodine-131 ablative therapy. The latter group, who had received surgery and ablation therapy, had the least recurrence and also virtually no mortality. These data strongly supported the practice of adjuvant therapy, which is now standard clinical practice, often involving administration of doses to remove unconfirmed residual tumour and, of course, any treatment of recurrent disease. In recent years, progress in the understanding of tumour genomics has identified mutations in a subset of certain thyroid cancer patients that results in a loss of iodine trapping. Although it's not completely understood, the radiopharmaceuticals classified as tyrosine kinase inhibitors have been developed and go some way to inhibit the adverse mutations and thus restore iodine trapping within these tumours. You can see a published example here where the image on the left is a whole body iodine-131 scan and on the right the same scan repeated after 14 days of receiving tyrosine kinase inhibitor, demonstrating the restoration of iodine uptake and so now suitability of this patient to go on for iodine therapy. By incorporating the iodine-131 atom into other molecules, targeted radionuclide therapy in malignancies other than thyroid disease have now become possible. An example is the use of I-131 MRBG, which can target and treat unresectable or metastatic pheochromocytoma and paragangliomas, as well as medullary carcinoma, for which no other targeted treatment options are available. Despite years of use in a research setting, FDA approval has only recently been gained. A well-known product for the treatment of non-Hodgkin's lymphoma is Bexxar, which is a form of radioimmunotherapy using monoclonal antibody labeled with iodine-131 to target the CD20 positive disease. Y90 has also been used as an alternative to iodine-131 in this setting. It has a more energetic beta particle which may be useful for treatment of bulkier disease due to the extended range and shorter half-life. Given yttrium-90 is a radiometal, it also tends to have a stronger molecular bond to the carrier. Unfortunately, however, it's not ideal for imaging, as there's no direct gamma emission as we have with iodine. Due to the lack of availability in Australia, most likely due to few clinical trials, Harvey Turner, a doctor in Perth, has developed his own version of Bexxar by labelling rituximab with I-131 and has reported very similar results to overseas. The next major development in radionuclide therapy was in targeted treatment of neuroendocrine tumours. Treatment utilises the fact that these tumours express somatostatin receptors which can be targeted with a somatostatin analogue called octreotide. This was originally developed and used as therapy for control of secretion of active metabolic products. Initially it was labelled with I-123 for imaging and then indium-111 for its longer half-life, labelled as Octreoscan. This development had a huge impact on the detection and management of NETs patients. Since NETs are often widespread, meaning surgery isn't an option, and there's no current particularly effective chemotherapy, symptoms are typically controlled with daily injections of octreotide. Such a disease was the perfect candidate for targeted radionuclide therapy. A radiolabel of both yttrium-90 and lutetium-177 has been used for targeted therapy in this setting. However, lutetium is more effective for therapy of micrometastases, probably because the absorbed fraction of the lower energy beta particle is greater than that of yttrium-90, and thus results in a greater radiation absorbed dose to the micrometastatic disease and more limited range in tissue, so thus less irradiation of any surrounding healthy tissue. Lutetium has the added advantage of being suitable for imaging with a 208 keV gamma emission, suitable for imaging on the gamma camera. A further development in the roadmap of radionuclide therapy occurred with the treatment of metastatic castrate-resistant prostate cancer. Prostate carcinoma is characterized by the expression of a surface marker called PSMA, prostate-specific membrane antigen. This is expressed in increased amounts, which relate to the aggressiveness of the tumor, something called the Gleason score. Both Y90 and lutetium have been used as a label to PSMA antibodies. However, Y90 tends to demonstrate greater adverse effects than lutetium. Given prostate cancer typically involves marrow with micrometastatic disease, it's not surprising that the high energy beta particle of Y90 can cause greater damage and toxicity to marrow cells. Organs at risk for such therapy are marrow and kidney. High tumour burden suggests risk becomes associated more with marrow and less with kidneys. Also, the salivary glands and possibly the lacrimal glands can suffer from toxicity following treatment. This is currently an active area of research. Published reports of very impressive clinical responses to PSMA therapy have led to trials and widespread use of this targeted radionuclide therapy. For example, the Therapy trial is a randomized study to compare lutetium PSMA with a type of chemotherapy called cabazitaxel, which is the standard treatment for advanced prostate cancer when other treatments have stopped working. Published findings released very recently show that lutetium PSMA compared with cabazitaxel in men who have metastatic castrate-resistant prostate cancer leads to a higher PSA response and fewer grade 3 or grade 4 adverse reaction. The paper states that lutetium PSMA is a new effective class of therapy and is a potential alternative to cabazitaxel. This is obviously a very exciting trial as it clearly demonstrates a radionuclide therapy could in fact replace a form of chemotherapy as a first-line treatment in patients with metastatic disease, whereas typically radionuclide therapy is often used as end-line treatment only when other forms of chemotherapy have failed. So I think this represents a very exciting step forward in our way of mention must also be given to alpha-emitting radionuclides that have in fact been an approved targeted cancer treatment since 2013. Targeted alpha therapy was first introduced in the form of radium-223 chloride, which is a bone-seeking agent and it mimics calcium. It was first used in castration-resistant prostate cancer patients who had symptomatic bone metastases, and it had only mild reported side effects due to very localized dose deposition. The clinical use was approved in 2013 by the FDA, and it was for a product formerly known as Alpha-Rad and currently known as Xofigo. Recently, a new form of targeted alpha therapy has been explored using alpha-emitting radionuclides complex to a chelator and conjugated to monoclonal antibodies. Due to the short path length of alpha particles and incomplete targeting, some cells' nuclei will unfortunately receive multiple hits or overkill, while others will receive no direct radiation. This can give rise to a heterogeneous irradiation of the target and dose deposition. Those cells that are not directly irradiated can still receive some therapeutic benefit by the bystander effect. Alpha-emitting radionuclides, which have been proposed for therapeutic application and are undergoing clinical investigation, include astatine-211, bismuth-212 and 213, actinium-225 and thorium-227. The image shown here is a published example of PSMA-targeted alpha radiation therapy with actinium-225. It's a first-in-human trial. The patient was originally treated with lutetium-labeled PSMA. However, after progression of disease and failure to respond to the beta-minus emitter, the patient was switched to the alpha label and achieved a very impressive response after multiple cycles. This demonstrates now typical practice where beta emitters are tried as the first line of radionuclide therapy to be replaced with an alpha label if no response is achieved. In this case, toxicity to salivary glands is of particular concern and, as I mentioned previously, an active area of research. It is also worth mentioning yttrium-90 selective internal radiation therapy, which technically still is considered a radionuclide therapy. However, it differs in that it's not a systemic treatment and has a mechanical targeting mechanism based on blood supply to tumours in the liver. As such, it more closely resembles a brachytherapy procedure. However, due to its static nature, with no change in biodistribution after initial delivery and lodgement, it's been a candidate for ideal dosimetry development methods in radionuclide therapy. In recent years, there have been significant advances in both hardware and software alongside the development of many of these radionuclide therapies and their diagnostic counterparts to allow for dosimetry to be performed in nuclear medicine, something which historically has not been done due to various limitations. Dosimetry is the use of absorbed dose estimates made from imaging or appropriate models that incorporate patient-specific information. The idea is to use dosimetry to tailor radionuclide therapy directly to the individual patient, with the hope of optimizing efficacy of treatment whilst minimizing risk. Such an approach is in keeping with the 2013 European mandate requiring all radionuclide therapies to incorporate some degree of dosimetry, a very large step forward in radionuclide therapy towards an act of standardization and optimization. Dosimetry has a role to play in all three stages of radionuclide therapy. This includes the treatment planning phase, a role that has been highlighted in recent years with the introduction of the term theranostics, utilizing the pairing of a diagnostic and therapeutic label to a given peptide, antibody, or similar, which essentially allows not just for suitable patients to be screened, yet also in some cases for predictive dosimetry to be performed. Predictive dosimetry allows dose estimates for treatment to be made and used to inform the prescription of the optimal amount of activity for therapy so as to deliver effective target doses, yet minimize risk to normal tissues based on safety dose limits. In order to perform predictive dosimetry, a diagnostic counterpart or surrogate of some form with an imaging label must be attached, or alternatively, very low doses of the therapeutic can be given, but for imaging and radiation dose purposes, this generally isn't ideal. The second phase is that of post-treatment assessment, which allows the therapeutic activity to be imaged to give information on the actual dose that was delivered to both targets and organs at risk. This can be used to predict response and make informed decisions about future therapies. Lastly, dosimetry is essential for comparison with response at follow-up, allowing us to build up our knowledge of what dose elicits what response for a given treatment and pathology. Information that will in the future feed back into the planning stage and so allow us to tailor therapy to the individual. Absorbed dose itself is measured as the energy deposited per unit mass and so is measured as joules per kilo, given in the unit Gray. In radionuclide therapy, we have to remember that the activity, and so disintegrations per second, are constantly reducing with time both due to physical decay and biological clearance, and as such, dose deposition occurs at an ever-decreasing rate. Beta particles are a form of low linear energy transfer radiation, and they act upon DNA through both single-strand breakages, which is a direct form of action, and through the creation of free radicals, which go on to have further reactions and cause indirect damage to the DNA. Alpha particles, on the other hand, can generate double-strand breakages in DNA, which are more difficult to repair. Given single-strand breakages can be repaired, allowing DNA and cells to recover from radiation damage, the dose rate, or rate of hits to the DNA, and the repair time, which will be specific to types of radiation and pathology, will have a direct bearing on how effective a given radionuclide therapy dose may be. It's also very important to keep in mind that the Gray we measure from radionuclide therapy is not readily comparable to the Gray measured in external beam radiotherapy. However, a lot of work to build our understanding of the radiobiological parameters and derivation of things such as biological effective dose are improving our understanding of this difference. In terms of the treatment planning phase, current practice generally sees a one-size-fits-all approach taken in the majority of radionuclide therapies, with some basic factors such as patient size or tumour burden being taken into consideration. Iodine therapy for the thyroid is currently varied based on risk factors and include things like patient age and the presence of metastatic disease, but otherwise quite a standard approach is taken. To this end, it generally takes on a standard 1 gig, 4 gig or 6 gig capsule. Due to its extensive success for many years, there may not be as much interest in refining this. However, there is some dosimetry work being done at certain centres with I-124 PET. Considering the other main types of radionuclide therapy, first looking at spheres or yttrium-90 microspheres. MAA in this case is used as a surrogate for the microspheres, which allows for treatment planning. Recent software developments have made such predictive dosimetry more accessible so that MAA imaging of the distribution in the liver allows for predictive dose maps to be generated, including dose volume histograms, leading to a more refined approach to prescribing activity for therapy specific to the patient. In terms of NETs treatment, there's a theranostic pairing between gallium-68 dotatate for screening and imaging of the therapeutic counterpart, lutetium dotatate. However, due to the short half-life of gallium-68, temporal imaging studies are not generally performed to allow for any type of predictive dosimetry. Indeed, this is an issue for many of the PET-labelled theranostic pairings, and as such, predictive dosimetry for NET treatments tends not to be done. I've got an example here of a different kind of pairing, theranostic pairing between an imaging agent, in this case copper-64, and a therapeutic agent, in this case copper-67. In this case, both were labelled to sartate, which generally can also be used for the treatment of NETs, as well as other things such as meningioma. The reason I'm showing this example is because copper-64 is a unique example of one of the few PET tracers that has a more longer-lived half-life that can allow for multiple imaging time points to be performed at the diagnostic stage and thus for predictive dosimetry potentially to be performed. The use of fluorine-18 and gallium-68 obviously for PSMA leads to the same limitation when it comes to predictive dosimetry for lutetium or actinium PSMA therapy. Planning dosimetry is not currently done based on this diagnostic image data, as the short half-life prevents suitable image timeframes allowed for adequate time points to be sampled and thus enabling dose estimates to be made. One potential workaround, in addition to looking at long-lived PET tracers, is swapping the gallium label from the positron-emitting short-lived gallium-68 to the much longer-lived gallium-67. Gallium-67 has been in use in nuclear medicine for over 50 years. In this article, it suggested that the longer-lived gallium-67, which has desirable characteristics for imaging with a gamma camera and a suitably long half-life to match biological timescales for drug uptake and turnover, has been overlooked, in particular for treatment planning with radionuclide therapy. Gallium-67 could also allow non-PET facilities to participate in theranostic imaging prior to therapy and for monitoring patient response after treatment. Gallium-67 could certainly play a niche role in the future development for personalised medicine with theranostics. As I previously mentioned, we should also keep in mind that there are a few long-lived PET isotopes that are available and may be more suitable as a theranostic pairing to allow for predictive dosimetry and treatment planning. These include iodine-124 with a 4.2-day half-life, copper-64, which I mentioned previously, that has a 12.7-hour half-life, and zirconium-89, which has a 78.4-hour half-life. There are limited examples in the literature of PET imaging, in this case up to 96 hours with iodine-124, which could allow for multiple time points to be captured and predictive dosimetry to be performed. It also has the additional benefit that the PET is inherently quantitative, so no specialised software is necessary, as may be the case for gamma camera imaging. In this respect, a long-lived positron emitter offers an ideal solution to the theranostic component for treatment planning. In terms of post-treatment assessment and what the current practice is, relatively recent developments in quantitative SPECT in particular have seen an improvement in current practice. Looking at the main radionuclide therapies that we've discussed, yttrium-90 microspheres is a unique point in case, as only a single time point of imaging is necessary given the distribution is static after injection, so no biological clearance is seen and there's only physical decay of Y90. In this respect, dosimetry is relatively easy. Y90 can be imaged and quantified on the PET scanner, in particular time-of-flight systems. In this case, post-treatment PET offers a reliable way of confirming administered activity and delivered dose to both targets and normal parenchyma. And there are also several vendor-supplied and approved software packages available offering very advanced dosimetry tools. Post-treatment assessment of NETs and also metastatic castrate-resistant prostate cancer treated with radionuclide therapy has seen some very rapid advances with the introduction of vendor-supported quantitative SPECT. There are also vendor-based specific dosimetry packages becoming available, all leading towards standardization in our approach to dosimetry. For such radionuclide therapies where the distribution is changing with time, imaging must be used to capture the uptake phase and in particular the peak of uptake and the clearance, allowing time activity curves to be derived for dose estimates. At least 3 time points are recommended to fit generally bi-exponential clearance curves, including a late time point, where the later the better to fit the curve more accurately. Yet there's also obviously a trade-off with image noise due to the lower counts available. Fitting time activity curves and using dose models such as MERD and Alinda EXM allows dose estimates to be made of organs of interest such as kidneys. Alternatively, voxel-based dosimetry can generate dose maps, giving greater flexibility in estimating not just standard dose statistics, but also additional parameters from dose volume histograms. Access to vendor-based software for quantification and dosimetry that has gained FDA, TGA, or CE approval goes a long way to making such techniques accessible and towards standardization across sites. The current practice in terms of mapping dose to the response measured at follow-up varies a lot across sites. Some sites will still be using RECIST-type measures, and nuclear medicine departments may not see patients return in an adequate time frame post-therapy. However, more and more we're relying on functional imaging to indicate response, and this is certainly the case for patients receiving treatment for NETs and widespread metastatic castrate-resistant prostate cancer in conjunction with biomarkers like PSA levels. Comparison of changes in SUV or TLG with dose given at therapy derived from dosimetry imaging offers valuable insight into what our targeted threshold doses should be and thus shaping the future directions of personalized radionuclide therapy. There are more and more published examples of significant dose-response relationships being detected, seen for example here in Y90 microspheres and also in castrate-resistant prostate cancer treated with lutetium PSMA. However, pathologies such as NETs can be more challenging to establish dose-response information, as we often don't see a change in imaging. However, patients may still have relief of symptoms and a vast improvement in quality of life. Castrate-resistant prostate cancer is an example of having a very suitable biomarker for response, in this case changing levels of PSA in blood, which gives us another point of comparison for changes in imaging. In the same way that molecular compounds have a complex design of integrating components to target specific biological processes, we also need to appreciate the myriad of factors that must be integrated and optimized when personalizing radionuclide therapy and targeting an individual's disease to provide optimal outcome. There are many advances occurring in the area of imaging, as well as in our understanding of some of the fundamental factors that are influencing the future direction we're going to see radionuclide therapy heading. These are a few examples of what I see as some key areas that will shape this. Looking first at hardware developments. Of course, digital detectors are having an impact on technology. Cadmium zinc telluride detector technology uses digital semiconductor detectors that offer improved sensitivity, speed, and greater energy resolution. They help to recover losses in spatial resolution, improve scan time or reduce patient dose, and improve the energy resolution, which lends itself very readily to simultaneous multi-tracer studies in SPECT. We're seeing digital detectors becoming available in specialized gamma cameras, as well as digital PET now available from all 3 of the major vendors. Whole-body SPECT-CT is also becoming more widely available, which makes SPECT-CT data much more PET-like. This is a powerful tool that has the potential to change standard clinical practice, perhaps removing the need for whole-body planar imaging plus additional regional SPECT-CT. This could have huge time-saving implications for both patients and staff managing equipment. Dynamic SPECT is also a relatively new tool that has become available and certainly may have a role to play in the management of radionuclide therapy patients. You can see here an example looking at dynamic SPECT for early start HIDA uptake, courtesy of Peter Kench at the Sydney University. In the lower left corner, we have the scanner moving in dynamic mode. The camera is working currently in its fastest mode, which equals 15 seconds per SPECT study or per whole rotation, which is a really impressive speed. 10 seconds of that is related to data collection, and there's a period of detector rotation, deacceleration, and acceleration during which there's no acquisition. Even at such limited acquisition times per angle of rotation, you can see that the data is still of a quality that allows for quantification. Looking now at software developments and the impact on the direction of radionuclide therapy. Certainly, the introduction of quantitative SPECT has and will continue to have a large impact on the ability to perform dosimetry for radionuclide therapies. Resulting reconstructions are in units of becquerels per mil, just as a PET scan would be, and data can be displayed with SUV where desirable, or converted to dose with units of temporal imaging. Further developments in association with this include advances in algorithm technology for real-time dead time loss correction and the ability to deal with high count rates from theranostics procedures. Additional technology, such as the Siemens XBEC bone algorithm, uses the CT as a frame of reference for reconstruction, extracting skeletal zone maps to delineate the boundaries of tracer uptake and thus improving resolution of the reconstructed data. Partial volume effects have long been a fundamental issue with SPECT imaging, where resolution limits have placed barriers on the accuracy with which we can derive quantitative values, particularly in small areas of uptake such as small lesions, when assessing dosimetry. For several years, vendors have offered resolution recovery based on the point spread function of the imaging system, which goes some way to addressing these losses in resolution and reconstructed concentration values within small structures. However, unfortunately, this is often at the cost of introduced artifacts, usually seen as ringing, known as Gibbs artifacts. However, there have been some promising developments, including this example here of the theranostic SPECT image reconstruction proposed by one of our PhD students, where the diagnostic PET counterpart is used to guide image reconstruction of the post-therapy SPECT data, acting as a prior using the HKEM reconstruction algorithm, similar in the way CT is used for zoning and reconstruction of bone SPECT. The results seen here in an example of a copper-67 meningioma study reconstructed with guidance from the diagnostic copper-64 PET study show a remarkable improvement in the SPECT reconstructed resolution, which becomes comparable in terms of quality and quantitative accuracy to the PET study without the introduction of artifacts that are commonly seen in the typical resolution recovery algorithms. A major advance in radionuclide therapy has been seen with the introduction of approved dosimetry software, which has primarily been developed first for yttrium-90 and is now extending towards other therapies and isotopes. Once again, the type of software is absolutely necessary to achieve standardization and a uniform approach to improving radionuclide therapy, an area where medical physicists play an important role which will only continue to grow in clinical nuclear medicine. It's also worth highlighting the use of AI for automated organ segmentation. Dosimetry for radionuclide therapy is incredibly time-consuming, largely due to the need for individual organ segmentation. However, very sophisticated tools are becoming available, allowing for automated or semi-automated organ segmentation, which could lead to massive savings in time and make individual patient dosimetry much more feasible on a patient-by-patient basis. Considering the radiobiology of radionuclide therapy and how this is shaping change. There's a lot we still don't understand on this point, as historically all our information of radiobiology has been gained from external beam radiotherapy, which is clearly very different to radionuclide therapy in terms of the type of radiation, cell kill mechanisms, and of course the dose rate, which is vastly different. However, publications are appearing looking specifically at derivation of radiobiological parameters for common radionuclide therapy isotopes and for given pathologies of interest. An example can be seen here of an in vitro prostate cancer cell experiment mapping cell survival curves after irradiation with external beam in black compared to gallium-68 and also yttrium-90 seen in blue. It's evident that there is a large difference between the shape of the cell survival curves, and in this case we can see that achieving a cell survival rate of about 0.1% corresponds to roughly 8 gray of external beam radiotherapy. However, the same survival rate requires over 60 gray of yttrium-90. It's a really nice example of why the gray for each therapy is not readily comparable. We're also seeing published data, such as this example here, looking at the clinical impact of dosimetry on radionuclide therapy patients, certainly indicating that radionuclide therapy is moving in the right direction. We have nice software applications becoming available, such as this example from MIM software, which offer modelling of tumour control probabilities. Various models, including linear quadratic low dose rate models, can be defined with specific alpha-beta ratios, tumour repair times, and so on. These can be defined for various isotopes, pathologies, and used to estimate tumor control probabilities following dosimetry. Such data is incredibly valuable to collect so it can be compared to response, allowing us to determine which of these models is most valuable with the most significant predictive power, and in the future these validated models might be able to be used to predict response immediately after radionuclide therapy is performed, enabling us to make informed decisions regarding future treatment and patient management. Also, this example of a structured report shown here, generated on a patient-by-patient basis after radionuclide therapy, can offer information on contour doses and whether or not they have reached pre-specified targets or thresholds. Such displays are a consistent way of capturing radionuclide therapy results and dosimetry data for each of our patients, and can also be fed back to the referrer or others involved in the patient management. All of this sees radionuclide therapy moving more and more in the direction of external beam radiotherapy, which has had such well-established protocols in place for a very long time. The last thing I wanted to mention are some new approaches that may potentially shape the future of radionuclide therapy. One example of a new way of looking at radionuclide therapy that, to my knowledge, has not been considered before is this recently published potential of using positrons for treatment of cancer by one of our PhD students. This is a proof of concept study demonstrating the therapeutic effect of positron emitters and development of radiobiological parameters for fluorine 18. It gives the first in vitro evidence of cytotoxic effects of 20 gray of fluorine 18 on prostate cancer cells. Simulations were used to investigate thermalized positrons that traverse the DNA with a lethal effect due to highly localized energy deposition during the thermalization and annihilation process, which leads to magnified cell kill effect when compared to electrons or beta minus particles that traverse the same material. The image is an example of cell survival curves of prostate cancer cells exposed to fluorine 18 and high-energy X-rays in the external beam radiotherapy equivalent platform, demonstrating comparison of alpha-beta parameters. Such work exploits the shorter half-life of positron emitters also, meaning we can give very high levels of activity to provide a high initial rate of single-strand breakages in DNA. That way, overcome the repair time and overwhelm cells, leading to a higher cell death when compared to the same dose from a more long-lived counterpart. It's certainly a very interesting way of thinking and something I suspect we'll be hearing more about in the coming years as we look to expand the suite of radionuclide therapies that are becoming available, and certainly as we look to improve their effectiveness. Thank you for your attention. I apologise I can't be there live to answer any questions, but I'm very happy to do so via email.